we are on live now, so we can start.
Thank you. So, good evening, everyone. I am pleased to welcome you all to the fourth session of our ongoing webinar series on respiratory allergy and allergen immunotherapy. As usual, this is being brought to you by Stella Greer in collaboration with the Gulf Allergy and Clinical Immunology Society. Over the past few months, this series has brought together leading experts and engaged audiences from across the region to share knowledge and best practices on allergy care. And today we are excited to continue this journey with two distinguished speakers. We have today with us Dr. Mariam Al-Nasf from Qatar and Dr. Adib Bulkhi from Saudi Arabia. We are honored to have you both with us today, Dr. Mariam and Dr. Adib, and we look forward to your insights. And as always, we are also joined by our expert moderator, Dr. Muhammad Abu Zakouq, who will guide today's discussions as well. Just a note, if any of the audience have any comments or inquiries to Stella Greer, please you can share or ask any questions through the email showing in my background. It's info.me@stellagreer.com. Thank you all for joining us, and let's get started. Dr. Muhammad, over to you.
Many thanks, Muad, and Assalamu alaikum and good evening, everyone. Apologies for the unforeseen delay because it's just a technical issue. Internet is fantastic when everything goes well, but unfortunately there are hiccups here. And now, if you can you share your slides, because I think I have a problem with the slides here.
I will share from my side, sure.
Excellent. So I'd like to welcome you all to this very successful webinar series, which is really a collaborative initiative between the Gulf Academy of Allergy and Clinical Immunology and Stella Greer Pharmaceutical Company. This is a 6-month series which will explore various aspects of respiratory allergy and allergen immunotherapy. Both areas are important therapeutic and active areas, but there is a wide, range of fictions about it, and there are lots of things that we need to understand about them. Now, can you move your slides, Maad? Because I don't see the slides there. Again, I'm not seeing the slides.
I think you can't see the slides?
No. We'll try again.
What about now?
Let me have a look. Still, I can't see your slide. Can you share your slide? Can you share your slides?
I am sharing.
We can see the slides. Maybe Bro Muhammad.
I can't see your slides for some reason. Maad?
I think audience can see the slides.
Oh, excellent. Oh, that's just good.
Okay.
Okay, just let me, I don't know what's happening there, but okay. Spare 1 second. Okay, so for some reason I can't see the slides, but anyway, this is as we said earlier, a collaborative project, and we thus far had about 4 sessions. So this is our 3 sessions. This is the 4th, and each session features a national, regional, and international experts in the field of allergy and clinical immunology, with discussing the latest advances and therapeutic options over 2 hours. As Muad said, it's very important that you participate in these sessions, because it's for us to learn and to share experience, and really it's really very, very important. You send your questions at the end of the Q&A session. Please submit them through the web there, and the guys will help you if you have any problems regarding that. Right. Just to give you a very, brief resume of what we're talking about. So the Gulf Academy of Allergy and Clinical Immunology is really a very active platform for education throughout the Gulf. The main aim of it is to share knowledge, amongst allergists and immunologists, as well as amongst other clinical fellows in the field of allergy and immunology, but also to spread the knowledge of allergy and immunology across the community of primary care, pulmonologists, ENT, internists, etc., who are really interested in the field of allergy and clinical immunology. So, and again, it's really a pleasure to have lots of experts from different countries, including Professor Mariam Al-Nusf and Dr. Al-Balkhi, amongst other colleagues and friends in different parts of the Gulf countries. And again, we grow with your participation, your comments, and your involvement, if you like, particularly those who are interested in the field of allergy and clinical immunology. Now, Stallergen Greer is a pharmaceutical company who's, as many of you would know, has a long history of producing reagents for allergy testing and allergen immunotherapy, and many of us have used these with great success over the years. Now, having said that, I think this is a brief introduction, if you like, and I apologize for the delay because I can't see the rest of the slides. We have two eminent speakers from our Gulf countries. Professor Mariam Nusf, who's a professor in allergy and immunology. She's a consultant and head of service in Hamad Medical Corporation. She's a wealth of knowledge in the area of allergy and clinical immunology. And we have Dr. Adib Al-Balkhi, who is again an eminent consultant in Jeddah, who is with a knowledgeable consultant in various aspects of allergy and clinical immunology. He's a professor with a track record of research. Both of them are, researchers as well as excellent clinicians. Tonight we have, a session on different aspects of immunotherapy, and again, I'm speaking from my memory now. So I think Professor Mariam is going to talk to us first, and then Dr. Adib. Is that correct?
Yes, indeed. Yes.
Okay, so I think without further ado, I'll let Professor Mariam Nusf to take us through her talk, and then we'll take the questions at the end. Thank you. Professor Mariam, the floor is yours.
Thank you so much, Prof. Abu Zaqouk. Can you hear me?
We can hear you and see you very well, yeah.
Very well.
And you can see my slides, okay?
Yes,
Good.
clear.
So I'll put it in presentation mode.
Better, yes.
Yeah. So again, thank you so much, Prof. Abu Zaqouk, for this nice introduction. Thanks, Stallergen Greer, for hosting this activity. I am Mariam Al-Nusf, and my talk today is about house dust mite induce allergic rhinitis, burden, diagnosis, and improved outcomes. It gives me a great pleasure to be in this session with Professor Adib Balkhi, who I really admire his work in the field of allergy and asthma. So I would like to begin the presentation by emphasizing the global prevalence of respiratory allergies, particularly those caused by house dust mite. House dust mite is the most frequent cause of allergies. And if we calculated the burden of allergic rhinitis globally, it is almost equal to 500 million patients. And for asthma, the prevalence is around 300 million patients. What about house dust mite allergy? It accounts for more than 50% of those allergic patients. So the burden is really high. It is important to understand the connection between the allergic rhinitis, asthma, and house dust mite. And to say that, that 49% of patients with rhinitis are house dust mite sensitized. On the other hand, or in the opposite, the patients with asthma, around 50 to 80% of them are house dust mite sensitized. This figure is an excellent. It shows us the house dust mite is number one most important allergy worldwide. I can definitely say that it is the more important and the more frequent allergens than any other allergens, no matter whether it is in USA, in Japan, in Middle East, Australia, or or Latin America. So it is very frequent. Let's go and look in particular for the Middle East. It is more than 20% compared to other allergens, as you can see. And this is expected because the Middle East is an area of a desert environment and desert ecosystem. And the dominant because of that, the structure of the environment is that we are all depending on the air conditioners and the air conditioned places. And these cold places, dark places that we are living in these modern cities, are the place where the dust mites are dominating. So this is in general about the house dust mite. I will just show the laser pointer. So this is the area of the Middle East where we are living. And if you take it as an example, you can definitely see it based on your also experience in your clinics. I want to take about a single example because I came from Qatar, so I'll speak about Qatar here. And the data almost consistently that being published from Qatar showing that house dust mite is the most predominant allergens since 2003 until 2023. Okay, and this is based on publications that been done in this area. Now let me speak about some misconception of mite allergy. The mite contact occurs, is it only during the sleep? No, the answer is no, because all data, the recent data and the old data support that 90% of contact happens outside the bed, meaning that the mites are staying on our skin, staying on our clothes and our hair, and we can say everywhere. So we are continue to have exposure to these allergen all the day. More than 90% of exposure happen during the daytime. And this explains why elimination measures have little impact. Okay, now I will go deeper for a few studies that support the importance of house dust mite as allergens in the field of allergy and in the field of respiratory diseases. I would like to speak first about the SMAP study. And this SMAP study is a survey that was done in house dust mite induced respiratory allergies involving more than 300 participants. It is a survey, as I mentioned, of people with allergy characterized by house dust mite. Okay, and the purpose was to better understand how dust mite burden in these patients. Okay, and this included 13 months of clinical evaluations using questionnaires for these patients, as you can see here, from the timeline of experience per month experience of these patients. What interesting about these data and what we learned from this survey, that symptoms of house dust mite in allergic patients are perennial, as you can see. Okay, it is all the year in nose and in eyes. And also this is reflected by the consultation rate that happens during that period. This have a big burden on patients in respect to the symptoms, and increase all over. There are a few dips that you can see it during the autumn. I don't know if you can see here, like in September, or this area, as well as in spring, which is like in March, April time. And this dip also in the consultation visits have happen, for different reasons. Um, there are also period that patients may feel better. Okay, so the most important idea that these are perennial, and it is, uh, this is important, and a very important concept that I want to raise it for you, that these patients will come to you and feel that they are normal. So it is not like the seasonal symptoms, because during the season, patients will have like a peak and they will come with severe diseases. But here they will come all over the year. So they feel also that they are normal. Also, the physician who are treating them, when he asking them and the question, they will describe it as this is, yeah, this is normal. This is not a big deal for us. Okay, and this is not a real disease. They believe that it is not a real disease. So, because of that, the nature of persistence disease, this will give the rise of the perception about the patients that this is not a real disease, and these sufferer patients believe that pollen allergy is more severe. Also, this concept happen also between the physicians. They will believe that these patients have, more severe diseases and more burden, although these patients are suffer for longer time and they have more diseases. Okay, so the second important point from that one is that these patients have more than 60% moderate or severe allergic rhinitis, and more than 60% of these patients will be considered with nasal symptoms extremely or very disturbing. So it impacts the quality of life in a very strong way due to multiple and different symptoms like sneezing, a blocked nose, runny nose, itchy nose, tearing, and itchy eyes. I showed previously that these patients are struggling from these symptoms all the year round, but they are addressing doctors mostly on the periods when their symptoms are severe or exacerbated. And maybe sometimes these symptoms will reduce, as you can see here from this SMAP study, that sometime in the year there are a drop, like early and late August, which is the summertime, maybe because of their vacations and different travels. So, this longer duration of their symptoms give us an impression about the type of symptoms and the type of diseases, and why they are seeking the medical help throughout the year. This study also show us very interesting data. Excuse me, I will just, improve that one, so to show the full slide here. You can see here that from the SMAP study also, that it show us that these patients have a very long lasting complex history, and they have it for more than 13 years in average, from the time when they start to have their symptoms to the time when they first visit the allergy doctors. So more than 10 years of suffer. This is performed in 3 European green study countries, which are Italy, France, and Spain. but the focus was about house dust mite that showed to be a significantly a big burden. You can see that these patients are visiting multiple doctors, including GP, allergologist, ENT, dermatologist, pediatricians, to help them to resolve their symptoms. And if you look at this second slide, you will see that in addition to that, they will have more of, don't know how to remove this one. Long history of prescription of a lot of medications and characterized by expansion of the spectrum of sensitization. So you can see here that by percentage, like more than 80 or around 80% to between 65 to 80%, they will have a multimorbid with the grass, pollen allergies, similarly the cat and dog, because all these are modern cities house allergies. Also, the prevalence of multimorbids, I like the terminology of multimorbid rather than the comorbids, based on the new study that been published recently about the presence of these diseases of allergic rhinitis and asthma as multimorbid rather than comorbids across the different age of patients by John Boskid. So you can see here that these multimorbids include sinusitis, otitis media, and otitis, and conjunctivitis with conjunctivitis and headache, the most prevalent in these patients. Okay, now we like to see the difference between the adult and children in the presentation. And the grown up. What are the commonest symptoms between each group? You can see here that in the adult, the sleep disturbance is the commonest, around accounting for 75%, while the pediatric, the commonest is the nasal obstruction and the sleep disturbance coming little down. For another study, if we look for the effect on the quality of life, you can see that it is negatively impacts all the domains that been done in this questionnaire that been published in 2017 to assess the quality of life, including the daily activity, the sleep pattern, the non-nose, non-eye symptoms, the practical problems, nasal symptoms, eye symptoms, and the emotion. Also, more than 80% of patients with moderate to severe allergic rhinitis have decreased their daily activities. And because of that, sleep disturbances may lead to next day daytime fatigue, also increase in sleepiness or decrease sleepiness during the nighttime, and decrease cognitive function. Again, these symptoms are debilitating and have significant negative impact and associated with sleep disturbance and may cause daytime fatigue and irritability. Gradually over time, patients suffer symptoms during not only the nighttime, it will be day and nighttime around the year. And due to this constant presence of mite allergens, the life burden of patient is worse than for those with pollen allergy, because this is only seasonal. So, house dust mite-induced allergic rhinitis should be considered as a prognostic risk factor for development of asthma. This is mainly in a particular group of patients. And you can see here that long-term studies showed patients with house dust mite-related allergic rhinitis have a higher risk of development of asthma than the general population, and a higher risk of patients with allergic rhinitis caused by other allergens. Also, asthma patients who also have house dust mite-related allergic rhinitis have worse lung function and are more likely to experience recurrent exacerbations. So, what about the multimorbid diseases? Rhinitis is associated with allergic asthma, and 40% of patients with allergic rhinitis are reported to have concomitant asthma, and more than 90% of patients with house dust mite-induced asthma reported to have concomitant allergic rhinitis. The risk of development of new asthma symptoms is high in allergic rhinitis, as been reported by multiple studies and been proven with multiple studies. And this is higher first in a patients with allergic rhinitis, as you can see in this. However, also it is present with different type of allergic rhinitis because of animals or non-animals, and also because of pollens. As you can see here, the mites is the highest. So what about the development of asthma because of allergic rhinitis? It is estimated that approximately patients with allergic rhinitis, they will have 4 times more likely to develop asthma compared to the control. Okay, and this is a really significant burden. Also, approximately, it is 7 times higher than patient with children. Than patient, sorry, this next slide. This is the highest risk to develop asthma in children in this particular age group, which are 7 to 12. So if we look at that, it is 7 times higher in this group. It is 4 times higher in adolescent group, and it is almost 2 times in adult life. So it is the focus for development of asthma because of rhinitis should be targeted more in this particular group at first step. Okay, now I will speak about the burden on the medical services and resources. And allergic rhinitis with or without asthma, and this study that been done in France, showing that it is quite costly and have utilized a lot of medical resources to treat it. And whenever it is becoming more severe, either rhinitis or asthma, the burden is getting even higher. With the drug treatment or non-drug treatment, except the hospitalization. It may reach up to 68% for the severe rhinitis and up to the 40% for the asthma patients. House dust mite mediated allergic rhinitis also plays an important role in the pathogenesis of allergic diseases. So we always speak in the literature about the comorbids or the presence or concomitant allergic diseases with allergic rhinitis. And you can see here that the commonest one is the conjunctivitis, accounted for 36% of patients with allergic rhinitis. And similarly, it is quite high with rhinosinusitis and with nasal polyposis. So allergic sensitization is usually associated with these diseases. So now we reach the first part of this presentation, and I like you to have this take-home message about the burden of how dust mite allergic diseases and allergic and respiratory diseases. First of all, mite allergy is of global relevance, and allergic rhinitis can be leading to asthma. The highest risk of asthma development occurs in children with allergic rhinitis. So maybe this can suggest for us that maybe intervention at younger age is the preferable. Considering the chronic progressive course of allergy, timely allergy diagnostic is very important for the correct selection of therapy. It is not one single approach, it is actually a holistic approach that is needed and accounts for symptoms classically associated with allergic rhinitis. But also, we have to take it into consideration the physical and the mental parts of the patients that should be also addressed during the medication and prescription of a treatment. Finally, it is critical that clinicians gain a greater understanding of the unique burden of allergic rhinitis. So, allergic rhinitis and also of the burden of how dust mite in allergic rhinitis and in asthmatic patients. The second part of this presentation, I will focus about, we already discussed in the first part about the prevalence of house dust mite, about the allergic rhinitis worldwide, and how the problem is with allergy. And how the children are the highest risk with that, and the connection between allergic rhinitis, asthma, as well as with the house dust mite. Now we will focus about the house dust mite induced allergy is a real disease, not something that just a complaint that not really taken by the patients or by the physician. It has harmful symptoms and affects patients' quality of life, creating a significant disease burden. So what is the traditional treatment tactics? There are a lot of medication that can be given to the patients, and we have to be, careful about prescribing the traditional treatment and forgetting the source and treating the cause or the culprit of the disease, because this can lead to 100% cure in many patients, and this is what patients is looking for. So here, this is a small video that I like to show you, but I don't know how to, can't. So you can see here clearly the mites and this mites farm that are developed. And you can see here how they are, having a lot of complications, and because of themselves, the mites and the feces, and okay. Okay. So we go back for the laser pointer. Okay. So based on that, it is important to have effective measures to control rhinitis and asthma and these indoors allergens. So is avoidance measures enough for that? Let's see this based on evidence. One by one. Encase bedding in impermeable covers. Evidence of effect on allergen level is some, and it is advised that for non-adults, evidence A, some children evidence, none, I mean, evidence A, and some in some studies for children as evidence B. Wash bedding in a hot cycle, evidence is some, and evidence is A. For replace carpets with hard flooring, also none about it, but it's considered evidence. Okay, so at least these only three that can help. What about the other measures? It's all either weak or none is advised because of that. So, House dust mite control measures for asthma based on a systematic review are almost, unequal. So it is not, unfavorable for some positive compared to other treatment. Symptomatic treatment is also used by the majority of these patients. And I already spoke before about the burden on the health service and the cost that are the patient pay and the health service pay by, using controlled medication rather than treating the underlying cause. And to control these symptoms of allergic rhinitis that, you can see here, the use of antihistamine is considered very high in the age of 0 to 5, in the age of 6 to 10, in all age group. Okay, the nasal steroid sprays also with all its side effects, including eye issues, including the higher dose of nasal steroid that can be used, also account for around 50% in majority of patients. Eye drops and oral steroids also have a significant burden. It is not a small burden. So patients often overuse symptomatic treatment. And according to a study done in 2017, steroid use was excessive, accounting for almost half of all treatment used by patients. Together with nasal decongestants and oral antihistamines, these drugs account for 70% of the total pharmaceutical costs of approximately 106.5 per patients per year. All symptomatic treatments work to suppress symptoms rather than to eliminate the underlying disease, as we already explained. Self-medication in patients with persistent rhinitis is very common, and one of the major problem is the utilizing of decongestant medications. In almost half of these patients, you can see that 70% who buy nasal decongestant are considered chronic abusers, and almost like 50% of them have chronic abusers. So these are quite a problem, for especially that you know that decongestant has a lot of significant side effects on the long run. So also this is the same for traditional therapeutic management of patients with allergies when it is insufficient. Symptomatic drugs do not slow or halt the progression of the disease. Many patients will continue to suffer allergy symptoms despite optimal pharmacotherapy, and 1 out of 5 patients with allergic rhinitis will continue to have uncontrolled or not properly controlled symptoms by using the symptomatic drugs alone. So the final message from this part of the talk is that 30 to 40% of allergic rhinitis sufferers are not satisfied with their current treatment. Most patients want to be cured from their allergy diseases, and I think you may all reach the point what we need to give them to cure them and to relieve them from this disease and this burden. Okay, now I will speak about the third part, which are the different therapeutic approaches in controlling and in on different parameters. I am comparing here the allergen immunotherapy, the corticosteroid, antihistamine, and leukotriene antagonist. For the symptom control during the treatment, all of them will work. Okay, but only allergen immunotherapy will be effective on the mechanism of the allergy and on the long-lasting effect. So, allergen immunotherapy is the recommended treatment based on multiple societies and organizations internationally. Even in our guidelines from the UAE that been recently published, allergen immunotherapy was also recommended. So this is from area guidelines, and you can see here that it is clearly recommended in their guidelines from the IACI and from the World Allergy Organization. Allergen immunotherapy may prevent worsening and progression of respiratory allergies. So based on the WOW, the preventive benefits of allergen immunotherapy may be greater if initiated early in the course of allergic diseases. So I am only quoting some sentences from these guidelines. What Iyaki said that a 3-year course of allergen immunotherapy reduces the likelihood that children and adolescents with allergic rhinitis driven by pollen allergy go on to develop asthma up to 2 years post allergen immunotherapy. And for the area, they say that in children, allergen immunotherapy may prevent the asthma onset in patients with allergic rhinitis. So clearly, the recommendations is in favor of allergen immunotherapy for patients and especially in suffering from house dust mite or chronic diseases like that. So the recommendations for management of allergic rhinitis by area recommendations based on the severity and the frequency of symptoms give us the hint that, you know, whenever the patients reach the level of moderate to severe, either intermittent, old mild persistent, or moderate to severe persistent, there are this place to go for allergen immunotherapy at all these steps. So you can go with some symptomatic treatment. However, if you want some, you know, more and more a better option, you have you can go for the allergen immunotherapy. Unfortunately, we always put this at the like a final option, but we really need to put it higher in these guidelines as one of the first options. Because, you know, we all know about the atopic march. And it may be that by giving allergen immunotherapy early, we may reach some sort of a prevention of atopic march or other diseases development. And childhood and adolescence are critical phase for development and the progression of atopic respiratory diseases. And the windows of vulnerability is this period, which is the young age. And on the other periods of possible effective influence on pathogenesis of the disease. So we have no time to waste. We have to think critically and go ahead. So the general indications are allergen immunotherapy should be considered when all of these criteria are met. First, symptoms strongly suggestive of allergic rhinitis with or without conjunctivitis. There is evidence of IgE sensitization either by positive skin prick test or specific IgE by blood test to one or more clinically relevant allergens. And what is more relevant than house dust mite, which is really dominating in our environment. Number 3 is the experience of moderate to severe symptoms which interfere with the usual daily activities or sleep despite regular and appropriate pharmacotherapy and or the utilization of avoidance strategies that are not useful for this patient. allergen immunotherapy may also be considered in less severe allergic rhinitis. When is that? When the patient wishes to wish to take advantage of its long-term effect on allergic rhinitis and the potential of particularly grass pollen to prevent asthma. The standardized allergen-specific immunotherapy or products with clinically documented evidence of efficacy should be always used. And, you know, in 2020, Oliver Buffer mentioned in his guidelines for allergic rhinoconjunctivitis something very interesting about utilizing or selection of products, because you know not all products are the same, and all products should be checked properly according to the patients and should be evaluated. Also, Oliver Pafar published their websites from Germany, where there are a lot of multiple studies are rated according to the level of evidence, if it is done with phase 1 up to phase 3 or even beyond that, and these information are quite important for us. Let's go now for the preventive effects of allergen immunotherapy for asthma. And you can see here that this is a systematic review and meta-analysis of randomized and non-randomized control studies. And they included 18 studies. And just imagine how many patients are there under evaluation. It was more than 300,000 participants of different types: SCIT, SLIT, or drops or SLIT tablets. And you can see that the shift is more toward the positive for almost majority of these studies. So as a result of that, we can say that allergen immunotherapy have a possible preventive effect on asthma onset, especially in children and monosensitized, and if it is used for at least 3 years of therapy. And you can see here that the risk of bias and heterogeneity was not high in this particular study, which is really very good study. And this is very recent. It's almost like 3 years ago being published. Here we reach that expanding options in house dust mite allergic rhinitis for optimizing the patient outcomes. So it is critical that clinicians gain a greater understanding of the unique burden of allergic rhinitis, and that we have to improve patients' outcomes by better treating them. We have to utilize the idea of early prevention and early treatment with allergen immunotherapy, because this is crucially important, especially in children. So, as I mentioned, we have no time to waste, and we have to start. By that, I reached the end of my slides, and I like to thank Salajan Greer for hosting us and Gaki for this initiative to increase the awareness about allergen immunotherapy and particularly house dust mite allergen. I like to thank my group from Hamad Medical Corporation, who are, working very hard to elevate and increase the awareness. Now we are preparing for the second awareness campaign that's coming soon for the Allergy Week. And thank you so much, everybody who participated in this activity, and for your patience to listen to us. Thank you.
Fantastic, Prof. Mariam. Wallahi, it's an excellent presentation. Excellent. It's very, very informative, concise, succinct overview of house dust mite allergy. And I think, it will stimulate I have lots of questions for you, so be prepared.
I'm ready.
So we'll take the questions. All right. I'm sure you are. You're the expert. So please, we have more about 270 participants. So this is an excellent participation. So please keep your questions coming into the into the QA section if you like. Now we're moving on swiftly. So to Prof. Adib, who's going to talk to us about house dust mite-induced allergic rhinitis. And this time we're talking about improved outcomes. So Dr. Adib, the floor is yours. Thank you. You're muted, so.
السلام عليكم ورحمة الله وبركاته.
الله وبركاته.
مساء الخير على الجميع. Good evening, everyone. Thank you so much, Prof. Muhammad, for the introduction, and thanks for Gaki and Salih Greer for the host. And thank you so much, Prof. Mariam, for the enlightenment introduction and really overview of the importance of allergy immunotherapy. I think this is our time, and this is the time where basically showing that this is not only an effective treatment, but actually it's a curative, so quote unquote, disease modifying, hopefully treatment that we can offer to our patients who is allergic to allergens. Without further ado, I will share my slides. 1 second. All right. I hope my slides is clear and seen by everyone. So, completing the talk where Dr. Mariam and Prof. Mariam mentioned and took over, we really want to highlight a few things in the next upcoming few minutes. We're basically addressing many points when it comes to house dust mite and house dust mite allergy. This already has been presented with Dr. Mariam. We're basically showing that this is it's a really prevalent disease, and everyone who's participating now in this webinar, at least has majority of his or her patients having allergic rhinitis or having allergic asthma. So it's a prevalent disease, and we see it in our clinic frequently. It's estimated 500 million worldwide, but I think we don't have estimation in our region that really reflect the disease and how many patients among all of those suffering from either allergic asthma or allergic rhinitis, and specifically what type of sensitization that most patients they have. I'm talking about recent study. And it seems patients who are polysensitized, they have more severe disease. When we're talking about polysensitization, we're talking about they have more than one allergens involved in their allergic condition. And those patients, actually, it's not uncommon. But sometimes we can catch those patients early on where they are monosensitized, and we can help them, and try to cure, hopefully give them good option or good treatments. Now, this is what you usually avoid. I want to show the presenter. Okay. This is what they usually avoid to my patients to look into online when they start searching about dust mite. This is really not a lovely or a nice picture they imagine when what they are allergic from. And the idea just, it's under their own bed, and this is what they breathe and they expose to. It's not, a pleasant idea that most of the time when they think about dust mite allergy. But it's fact, this is a qualitative organism that we live with them. We can't live without them. And that's what I usually tell my patients. And it seems we have more than 2 species or 3 species if we include in Polymia tropicalis. Actually, there are more than 40,000 mite species, but the one it's relevant to allergy, that's what we call it, dermatophagoides terniasis and dermatophagosis ferniae. And in area where it's tropical, we see it mostly Bulimia tropicalis. And these organisms, they are really resilient, and they are live in a humid area. Usually I make this comment to my patients because when in Jeddah, which is very humid, and most of the coastal cities in the Gulf region, it's humid. I would say you're allergic to the city. You need to go to the mountains because it's less dust mites there. But I will say the only area that dust mite does not exist, it's basically the surface of the moon, because as long as we breathe and there's oxygen, dust mites is gonna be there. But they love darkness and they love humidity. So the more humid, the likelihood that this might will be exist. Now, it's most of the patients, they say, I changed the bed or I changed the mattress and I changed these things. I told them, whatever you do, they're going to come back again. So it's usually colonized within 1 year when you get this new home. All right. And this is what usually patients present to us. They have, mostly they are, they have symptoms, and that's why they end up landing in our clinics. They have, nasal symptoms that usually causing a lot of disturbance, headache, sinus headache, runny nose, post-nasal drip, and itchy nose and throat, where basically also some of them, they have conjunctivitis symptoms, like watery eyes, itchy eyes. All these symptoms collectively, it's really affecting the patient quality of life, the sleep quality of life, and sometimes they end up having more diseases like sleep apnea and so on forth due to these symptoms. Now we're going to go a little bit more technicality, and I think it's really relevant to what we're going to talk today, as well as I'm going to show you why it's relevant also in our clinical practice nowadays. Now, we think it's dust mites and it's only a single protein or single allergen, but in the fact, it's that single allergen. It has so many proteins in it, or in different parts of that allergens. The biggest 3 parts I want to focus on, they call it group 1 and group 2. Group 1, what they call it protease, and group 2, which is the lipid protein or lipid binding protein. This is the most common allergens that exist, and it's most prevalent that cause allergic symptoms besides sensitization. Recently, the introduction of group 23, which we call it Derby 23, it's become very prevalent, and it exists in the feces of the dust mites. We'll talk about it in details a little bit to just give you an idea. But these proteases and these proteins, it does not only activate the immune system. Actually, by itself, as the proteases, it causes destruction. It causes some effect on the tissue. It causes barrier defects to the epithelium, where basically it eats up the epithelium. It actually can go directly to the mast cells through MRGB XP, where basically activate the mast cell independently from IgE and Ig production. And it also can go to the airways, cause airway hyperresponsiveness or bronchospasm, as well as activate NLRP activation, where basically activate the inflammasomes, where patients start having symptoms like fatigue, lethargy that may be or induced by such activation or protease activity, and also break the immune tolerance. Now, these other allergens or groups, it's really becoming to the relevance, and its existence is really, have some clinical insights and meaningful. I'm talking about 4, 5, 7, and 21. The one we also see mostly, which is group 10, tropomycin, which has cross-reactivity with the shrimp and cockroaches. This is when you have some patients who have dust mite allergies. They have allergy to shrimp or cockroaches. Now, this is what we just discussed basically about these 2 groups and the proteases activity. But usually the group 1, it exists from the body itself, from gastrointestinal tract of the mites, and that it causes a lot of problems. Now, when you see it, and how the dust mites, specifically talking about proteases, it might activate different pathways that we think only related to allergy, but actually it's beyond that. As I mentioned, it can directly as a protease activity activate the mast cells, as I said, through the MRGBP2, or can activate the dendritic cells type 2. But actually, it can induce directly the innervation, the capsaicin receptor TRPV1, where basically induce the itching and induce what they call it lung itching. That's what usually patients tell us, I have itching in my chest, which is explaining like that feeling in their chest, as well as it can induce the itching in patients who has atopic dermatitis as well. So people who's in allergy ward, they understand the importance of Derby 1, Derby 2, DERF 1, DERF 2, which is group 1 and group 2, because this is what we've been taught and this is what been stressed out about the importance of those two allergens, which is true. This is the biggest two ones that really induce the allergy and sensitization in patients with this house dust mite allergy. But recently, the lot of light has been shed on the Derby 23, group 23, where basically it's showing it's becoming one of the major allergens that it does not exist in abundance like Derby 1 and Derby 2, but it really has a very clinical sensitization and clinical effect when it's resist. And usually it's produced by pieces of fecal materials of the dust mite. Now, it's been showing that patient who's been sensitized to Derby 23 alone can induce allergic rhinitis and asthma. So you don't have really to have Derby 1 and Derby 2 or DERF 1 or DERF 2 to have those sensitization, but existence of only Derby 23 actually can induce those allergic diseases. And unfortunately, it's underrepresented in diagnostic tests, either in skin test, if it's not a raw material and it's well prepared, or even in specific IG testing. Unless if you do resolved component testing, that's something that we're gonna quickly shed the light on it. So it's becoming very, very important, and we have to think about it when we have suspicion about someone with sensitization to the house dust mites. Now, this is one of the biggest cohort where basically they follow the patients for 9 years at different stages and different timeline, where basically they're trying to correlate the disease severity with sensitization. As you can see, almost majority of the patients and the prevalence of group 1, which you call it Derby 1, Derby 2, group 1 and 2, and group 23, they almost exist in most of the patients who is allergic or they have allergies. And it exists basically up to 70% of the patients. The least common, which is the other groups, they subgroup it to group B, which is Derby 5, Derby 7, Derby 4, and 21. But it has a very good clinical correlation as well. And last group, which is the rest of what we used to call it, or they showed to you before in the table, it's low of clinical significance. But actually, they are not. If they exist together, those patients who has only group 1 or group A, okay, group A, which is 1 and 2 and 23, the risk to develop allergic rhinitis and allergic asthma, it's about 2.3 odds ratio, or 2.3 higher chance compared to people who's not sensitized. But people, they have higher risk to develop allergic asthma and allergic rhinitis, up to 3 times if they have both. But what I want to clearly showing you, if you have combined group A and group B, your risk is going to be higher. And if you have all of those, you're going to be 7 times higher to develop, allergic asthma and allergic rhinitis, or individually allergic asthma or individually allergic rhinitis. Now, what's the relevance in this? Most of the patients, as you can see, they start with group A, which is the 3 major allergens. But if they left untreated or left with time, they end up developing other, sensitization to other component of allergic of dust mites. Now, that goes to really is that sensitization is really meaningful or not? In the big cohort that involved different groups or in different parts of the world, including about 700 allergic patients from Europe, Canada, US, and South Africa. People who has been sensitized mean they have positive test, mean they have the antibodies, but they don't really clinically having clinical symptoms, or they don't have, the disease or the diagnosis of asthma. It showed that people who have, group 2, including DERF 2 and Derby 2, and people with Derby 5, and people with Derby 21 and Derby 23, they are higher risk to develop asthma compared to people who is having lower from those allergens that give you insights that, existence of those allergens in a patient as a sensitization, the risk to develop asthma is going to be much higher compared to people who does not have these allergen or sensitization. And this is not only exists in asthma, but also shown in DERBY 23. It's a very good predictor of asthma in patients who is less than 5 years. And basically also the severity of asthma goes higher when the patient has DERBY 23. So it seems DERBY 23 has a very, very good correlation developing of asthma and asthma severity as well. And that's not only limited to asthma, but also showing in atopic dermatitis patients where they have DERBY 2, DERBY 5, DERBY 10, DERBY 23, and DERBY 20, and DERBY 21. They have higher risk to develop severe atopic dermatitis. Now, stopping derbies, talking about derbies and all things related to derbies, and I pretty much, had all these sometimes confusing. I remember when I was in fellowship, that's make a lot of, confusion, but really, it's really clinically relevant, and it's really has a good, meaningful clinical and as well treatment-wise. So let's say what's the importance of these literally complete molecular profile in products of house dust mites AIT. Now, I just showed you the science and how it really can correlate with the disease. But it seems is patients who has been sensitized to those allergens, they are having higher risk to develop asthma in different cohorts. Again, we are talking about DERBY 1, group 1, group 2, and group 23. Now, I know these Dr. Mariam or Prof. Mariam showed to you the cultures and how the dust mite has been qualitative and cultured, and it's been collected and probably how it's processed. But there's these allergens, they don't come from the same source. When I'm saying don't come from the same source, I'm not talking about the organism itself, because organism itself, which you call the body, it produces certain allergens, but part of the allergens comes from the feces of these, dust mites. So we have to collect, when we collect the whole culture, we have not only collecting the mites alone, but also we have to collect the byproducts of the mites, which has some allergens. We're talking about group 1 and group 23 basically comes from the allergy from the feces. So we extract the allergen, we have to take the whole culture, not only the body or the mites alone. And the good treatment that you could think, after I show you that we set the stage, that different allergens, it's really having good clinical correlation and clinical understanding why it's very important. So the good from that, the good product, it has to have all these major allergens and even intermediate allergens, and lucky us if we have even the low allergens, because as I showed to you, the higher risk of developing asthma, it goes higher when the patients have all these allergen sensitization. So it's amazing to have a product that has all the major allergens, but not excluding the intermediate or low allergens. And this is one of the biggest challenge in the world of immunotherapy. And people who's involved in this, they understand this too much. And this is why we have struggled, having what we call a standardization. And only a few allergens or immunotherapy has been standardized in US based on certain criteria to standardize, because it keeps changing from one lot to lot, and it keeps changing from one manufacturer to another manufacturer. And this is a very nice study where it showed basically between 9 products produced from Italy and about 4 products produced in France. You can see the variability between all the products in terms of DERBY 1 and DERBY 2, but some of them, they don't even have DERBY 5, 7, 10, and 21. It does not exist. This is show you the variability and the lack of data on the presence of concentration of other allergens like DERBY 23. So it's really one of the challenges that we face, and that sometimes make you lose faith in these medications, where basically patients take it and says, "Oh, I don't have any improvement," and that's one of the challenges that we see with these treatments. Now, I'm not just showing you here that it's not exist alone, but there's data has been shown in certain immunotherapy that only focusing on certain allergens like DERB1 or group 1 and group 2. Now, how we assess the clinical or biochemical response to the immunotherapy, we usually assess what we call it IgG4 or IgG antibodies, where basically it's the way how we assess if the patient after took the immunotherapy, he start to develop a new antibodies, but these new antibodies against IgG against the IgE. So this is the way how we assess immune response to the immunotherapy. And it shows in most of the immunotherapy that has been exist in the market, it's good correlation with IgG to DERB1 or group 1 here and group 2. But interestingly, when they checked for other groups like group 5, 7, 21, and 23, or the 5, 7, and 20, it's not exist. That means that allergen or immunotherapy does not have the allergen that would induce the immune system to produce IgG. But it does for 23 to group 1 and to, group 2 as well. And you would say, okay, so we don't need it. That's because we only focus on major allergens, which is 1, 2, and 23. But it seems clinically it's really meaningful, because a lot of patients who had been low effectiveness of immunotherapy, and when talking here we're talking about the black bars, it means poor responder. So poor responder, basically the one who is having higher or they didn't because they didn't have DERB5, DERB7, and DERB21, and sometimes DERB23. So it's really showing that absence of these allergens, it has some clinical meaningful. Now, what about another type of immunotherapy? What about the existence of other immunotherapy? Okay, which is basically allergoid. Allergoid, it's a type of immunotherapy where basically it's focusing on decreasing the allergenicity by keeping the immunogenicity. But again, it sometimes have some drawbacks when it comes with response on the existence of allergens. And it seems it's very good response with group 1 and group 2, but it's really showing no clinical response or existence of IgG to the DERB23. Now, this is really meaningful? Yes, because you can see here, this is basophil activation test where basically on patients who has been received these treatments, it's really suppressed the basophil activation. But in patients who is not exist, like in additional allergens like DERB23, and it's not exist basically, and the activation of basophil, it's there. So now we talked about some of the immunotherapy that exists in medicine, where basically it does not include all the allergens, and it does not really having response to these allergens, other allergens. What about there is a whole body, a whole culture immunotherapy that has the whole body and feces, and this is based on slit therapy. It has 300 IR, which was one of the biggest studies that assessing the double-blind placebo trial, assessing the effectiveness or the profile of house dust mite immunotherapy that has 300 IR. And basically this has been conducted on 100 patients. And it showed that indeed, when you give these 300 IR house dust mite slit, basically the antibodies production, IgG antibodies production, it goes up. And this is an indication that those allergens exist and the immune system has responded to those allergens by producing IgG. Now, one of the challenges that when we try to culture these organisms, the problem that the environment and the nature of these organisms, it's not easy because they live in human squamous cell. Actually, they eat our dead skin. And this is one of the arguments I used to tell my patients, if the desmite does not exist, basically by the end of the year, you will find a pile of shed of skin of your skin next to your bed because nobody eat those shedded skin or squamous cells. So, excuse me. So you really need to provide a good environment to culture those organisms. Unfortunately, we cannot utilize human squamous cells or similar to those because the hazard ratio about viruses, bacteria, and so on forth, it's high. And we're talking about, a product that can be given to human. So the certain manufacturer came up with scientific formula that trying to resemble and try to make it as close as the human squamous cell. And that's one of the key criteria to assess if this is a good manufacturing technique or not. The second criteria to assess, manufacturing technique, you have to do a very extensive proteomic characterization of the extract and make sure that every single allergen that of interest, it exists in the extract. Not only culturing and processing the product, but also you have to make sure that all the major allergens that we needed and patients needed for immunotherapy, it exists to give a clinical meaningful. Moving on, I hope that I established the importance of all these allergens and why these allergens is really clinically correlated with disease severity, and actually what's the treatment can lead to. I'm gonna spend like the next 5-10 minutes quickly talking about exactly the significance of the dose and the allergenic activity of the disease treatment. This is, I say, this is the fun part of immunology, where basically we're trying to really explain how the immunotherapy works. It's because we introduce an allergen to the system, we think, we probably gonna induce allergy. But actually the way how the immune skit or immunotherapy works is quite different. And I'll explain the next slide how it's working. But what we're trying to achieve by giving immunotherapy, we're trying to reteach immune system, trying to rebuild the immune system the natural way, if I could say, by inducing the Treg cells or the T cell regulatory cells, trying to induce the B regulatory cells, and trying to induce those cells under influence of IL-10 to produce IgG and IgG4, and another way also trying to suppress the effector cells from their activity. Now, this is very crucial and key. One of the smart questions I get in my clinic, and usually my patients tell me, okay, you're giving something that exists in the environment, but how it's going to help me? Because I already get in an environment and I'm still suffering. I'm not improving. This is what I usually tell them. It's a dose dependent. It's a dose dependent effect. So it seems that when we get in the environment, it's a low dose. And the low dose, it actually activate the Th2 pathway, which is the allergic pathway where basically IgG is being produced and causing all the allergies. But what we're trying to achieve with immunotherapy, it's we give high dose allergen that, hoping with that, we switch the gear from Th2 to Th1 and induce T regulatory cells to produce IgG and IgG4. That's the concept. And I was trying to to make it very simplistic and to make them to understand. It's like the aspirin. When you give it very high dose, you basically your anti-inflammatory effect. When you give very low dose, it's antiplatelet. So it's a dose-dependent effect. That's make patients understand the concept about immunotherapy. So dose, it's really important, and how much in there, it's really important. So it's not only what's in there in the immunotherapy, but the dose also has a very clinical importance and clinical efficacy. And it seems that 300 IR, it has the best dosing that really induced that. Lastly, in the last couple of slides, where basically I'm showing the effectiveness. Is this truly effective? The immunotherapy that we're giving is truly effective or not? Now, this is I think it's one of the landmark studies has showing, and it's really helped that these studies helped us to get these immunotherapy to the guidelines, because it's very well designed and has a very mechanistic showing that the clinical efficacy of the treatment. And it seems, in a group of patients, about 1,000 patients, they give you 1 to 1 to 1. with 3 different doses, 300 IR, 500 IR, and placebo, and they follow up over 52 weeks, which is 1 year, and they assess basically the adjusted symptom score. It seems after they give you the immunotherapy, patients within 8 to 10 weeks, we're talking about 2 months to 3 months, they have a significant improvement in their symptoms. And this is what time I usually tell my patients, when they ask me after I give the immunotherapy, when I should start feeling symptoms, or sorry, I start feeling improvement. I tell them between 2 to 3 months. This is how quick the immunotherapy, it works. This is a very good information, because when you tell your patients you need the medication for 3 to 5 years, they lose the hope and they think they're gonna have the benefit after 3 years. But by the evidence, it's really worked within 2 to 3 months. And that effect actually is improving over the time and sustained, and it's clearly showing difference compared to placebo. One of the key things also in this slide, and this is a message I really want you to pay attention to. It seems when we start immunotherapy, some patients and few patients, they start having higher IgE. That's why we refrain and we try not to repeat the IgE, or to repeat skin test sometimes in these patients, because it's going to come back positive and patients start having doubts. This medication is not working. I'm not having a good clinical effect, even though they clinically improved, but when they see the test and they see the numbers, they freak out. Unfortunately, clinically, we don't have it. It's only research-based, where basically, if we could measure the IgG4, it showed that numbers, it's really can be helpful to the patient to understand its medication is working, because this is what we utilize as quote unquote tolerance to the treatment. So the main message from that study was it's working very fast, almost from 2 to 3 months, and actually both IgG4 and IgE goes up. So we really focus on IgG4, but unfortunately this cannot be measured. But don't really measure this, because sometimes it's going to be confusing, and it's really very well effective treatment. Lastly, finishing with this one study and the other one, this is only in asthma. I just want to show you in asthma. In asthma, it shows that if you give this dose, it's really have a well-controlled asthma in patients who was on slit house dust mite, and total control of asthma in the majority of patients, and ACQ score is going to be much better. Not only that, but actually you reduce the inhaled corticosteroid to the lowest, if not stopping inhaled corticosteroid in these patients after 52 weeks of treatment. This is my last slide. I always say, and people knows me, I'm a big believer, not from phase 3, try to give us very good data, effectiveness of data. But actually, I love real world data, because this is what we have and this is what we do in our clinic. Now, this is to establish, and this is a 4-year study. It's been published from Japan and over 500 patients, where basically they're assessing the effectiveness and the symptom improvement when patients start on immunotherapy, specifically speaking about house dust mite. So as you can see, we are in agreement, like everywhere in the world. Most of the patients who start on immunotherapy, they are severe cases or severe symptoms or moderate symptoms. Very rarely we start patients on mild symptoms or asymptomatic patient. However, I agree with Dr. Mariam and Prof. Mariam when she said we don't have to waste, because we know it's going to be there. It's going to go there. It's just a matter of time. So the initial treatment we start, the better the response patient is going to be. So, but after 6 months of treatment, you will see a lot of patients, about 12%, they become asymptomatic. And some of them moved from moderate to severe to become mild, and the severity goes down with time. So the longer you be on immunotherapy, the more you become asymptomatic or you have milder symptoms. And pretty much about more than 95%, they become either mild symptoms or asymptomatic. That's showing you with time, the effectiveness goes up and patient become less symptomatic. So in summary, I want to summarize immunotherapy. It's already approved medications for patients with allergic rhinitis and allergic asthma. It's really, really effective at reducing the symptoms and reducing the symptomatic treatment in terms of inhaled corticosteroid or intranasal corticosteroid, actually it's prevent exacerbations of asthma, exacerbation of allergic rhinitis, and actually it's a disease modifying. This is a word I mentioned before. It's a disease modifying. It changed the nature of the disease. So this is one would think we call it quote unquote, cure, but you have to be careful with the word cure, but disease modifying and changing the disease nature. And we have to keep in mind, immunotherapy extract, it has to have all the ingredients, all the allergens that are really relevant to the patients. And this is very important. And the treatment should be easy, safe, and patient be adherent to it. One last thing I want to close with. Now, things, alhamdulillah, now there is a testing that really can tell us exactly what's the allergens in patient synthesized. This is, we call it resolved component testing. Now it exists in Saudi Arabia. It's called ALEX test, and Isaac, it's in other countries as well. These tests, it's really can help us define our patients and to give the right medications to the patients when we exactly know what's the allergens patient is sensitized. And with that, I conclude. Thank you so much.
Many thanks, Adib, Prof. Adib. That is really an excellent talk, and though a bit complicated, and you made it really very simple. So thank you very much indeed. I think all agree that we have an excellent session, a complete session, I should say, where we went from the prevalence, disease burden, to improved diagnostic testing, to improved outcomes, to state-of-the-art therapy for house mite allergy, which is really an important allergic disease that causes a lot of issues with the quality of life and induces asthma. I remains to thank our distinguished speakers for their excellent talks, and thank the participants for their persistence. We have about 270 participants still up to this hour, so that's really great. Now, I have a number of questions, but before moving into the audience questions, I'd like to ask Dr. Mariam about the prevalence of house dust mite allergy. So we know that house dust mite as an allergen is a perennial allergen, so it is there all year round. But is there evidence that this bug has a sort of, does it go through peaks? Throughout the year? I mean, is it more prevalent, for example, in the summer months here where, everything is air conditioned, or is it more prevalent in winter months? Because there is evidence that it is, although perennial, there is seasonality to it as well, where it is very high.
Yes, Prof. Muhammad, you are right, actually. All allergens, even the perennial, have seasons, and it depends also on multiple factors. I can tell you a story about, for example, the cat allergy. So the patients with the cat allergy, they will have a single cat, for example, and then you will give them immunotherapy, they will improve, then they will bring more cats at home. Okay, and this is a burden because it is not known to physicians, because the patients, they behave by themselves, and they don't inform. Similarly, the way how they live inside their houses, the degree of cleanliness, and the attitude of heating the bed sheets, all these things, we are not sure about it. So the crowdness, especially, we have a lot of intermediate categories of patients economically in our country. So these, maybe they don't have like the higher level of hygiene at their houses and their bedrooms. The problem with the dust mite is not only in the bedrooms, it can be even in the living room. And this is the fact that we ignore it as physicians, and we forget about it a lot. So we don't ask, we mainly ask them, okay, change your bedroom and focus on your bedroom. Okay, but it is actually across all the house. Similar to bed bugs, similar to a lot of, if it is one inside one room, it will be in the other room, definitely. Okay, so this is very common facts, and how it behave in different seasons because of the humidity. in our community of desert, we are all, you know, near the coast also. So the humidity is quite high. And this is a strong factor for the dust mite. During the summer time in our countries, the humidity reach very high, may reach at sometimes up to 80%, which is just to breathe in the air, you know. So for us, we suffer also for the dust mite. They like the humidity, so they are increasing. And these factors also should be, you know, considered. We don't have a clear data about the environmental because we need to measure it accurately inside the houses by doing it by specific test, by vacuuming and measure it across the whole year for multiple. And also we have to measure it to different area because also in mosque and people go
Absolutely.
and pray.
Yeah.
Yes, and we don't know. So we have to measure it. We have one time a project, me and Dr. Hassan with Qatar University, and we may do it actually to measure the different type of allergens, including in-house and indoor and outdoor, you know, allergens. So I think we need more studies to validate our hypothesis. Thank
Yeah,
you.
thank you very much indeed. I'll go back to we have a huge number of questions from the audience here, and the first one is about, and I think the answer we have it from your talks. Do you recommend as a first line for a newly diagnosed allergic rhinitis, moderate to severe, to be started on allergen immunotherapy? Dr. Prof.
Sure.
Adil.
Okay.
Yeah, for me, yes. The answer, the simple question is yes. I don't have to wait, especially if the patient started for allergic rhinitis, because the data clearly showed that patients who have allergic rhinitis, they're gonna easily progress to severe to asthma. So it's not only trying to minimize the symptoms, but also trying to prevent the disease progression as well. So my answer is yes.
Dr. Mariam, would
I
you
totally
concur with that?
agree with you. I totally agree with Prof. Balti about this answer. It's important to always make a clinical relevant of the allergen, and this is always I like it as a speak of my talks when I give it to anybody. The clinical relevance is, you know, based on the patient symptoms, you know, and patient environment. Okay, so whatever you will do to the patients, not only based on the skin prick test alone, it is based on the clinical factors that the patient come with. Take deep history from him, and from that you will justify, and you can also do a challenge. Okay, and the challenge now it is highly recommended in a lot of centers, and we are now in the process to developing our own challenge protocol for the nasal, for the eyes, you know, to identify these if they are real allergen, and then the direction of medication will be more specific and more correct. So always go for clinical relevance.
Yeah, we always will. We always, when we do our teaching, and in fact, one of the first sessions in this webinar series was about diagnosis, and I think you all agree that taking good history is really a very, very important or an essential part of the assessment. Particularly in our area, there are lots of there's no problem when a person is monosynthesized. The challenge is really when they're polysynthesized based on testing, etc. So I think history is your best tool for deciding. Plus, then the icing on the cake is testing. So I totally agree with you both. Now, there is an interesting question from Dr. Hassan Mubayyad. Dr. Hassan, I hope you're well. Thank you for your question. I thank the speakers for their great talks. We know that allergic conjunctivitis is common in pollen allergy. However, in house dust mite allergy, it does not look to be common. And even some experts think that allergic conjunctivitis shouldn't occur due to mite allergy, as the patient is closing eyes during sleep, so exposure is minimal. So that's a clever question. Any comments from both of you?
I will answer. You know, some of this question. It's completely correct. But to be honest with you, it's as Dr. Prof. Miriam mentioned. It's not only happening in the bedroom. It's not existing in the bedroom. when the people start dedusting their house, especially, around the holidays and all these things, they start having these allergic, conjunctivitis symptoms. Yes, it's not as common as hay fever that we see it with pollen, but really in our environment, especially with the dusty environment, and I'm talking about the place that I'm in. It's really not uncommon, to be honest with you. It's one of the things that we have to think that the patient has persistent conjunctivitis, and it shows the signs of allergic conjunctivitis, especially is associated with allergic rhinitis.
Dr. Mariam, any comments?
I can add to that actually. So I totally agree with Dr. Adi. So these dust mites are present in our skin and our clothes. Okay. So if I clean my house, I dust these, it will be on my clothes. Then I may just touch my eyes, as simple as that. And I transmit that one. Okay. Also, the particle size is not very big. So it can be
Airborne.
aerosol. So it can be, in the air available. So it can be transmitted, can be, inhaled, and it can precipitated on the conjunctiva. So by theory, it can cause isolated conjunctivitis, although it may be rare. The commonest is rhinoconjunctivitis. Okay, and some patients they have it rhinoconjunctivitis, but the rhinitis symptoms are less. That's why maybe they don't have, to describe it. But if you dig in their history, they will tell you, yes, I have nasal block, but doesn't bother me. What it bother me is the eye more. And in this case, you will treat him as rhinoconjunctivitis again. It is quite rare to have conjunctivitis alone without rhinitis for allergy. Okay.
Absolutely. Mm.
So this is, I think it should be considered always. Thank you.
I think I think I agree with you both. I think generally speaking, allergic eye disorders is usually the forgotten disease. I mean, people are troubled with their nose, they're troubled with their chest, but when it comes to their eyes, particularly if it's minimal, they forget about it, and they always relate it to dryness and the weather and whatever. But I think in my practice, I see quite a number of patients with house dust mite allergy and rhinoconjunctivitis, if you like. It's not uncommon. But again, like you said rightly, the house dust mites are everywhere, and they are, very, very prevalent. So, but remember, our environment is unique. Our ecosystem is unique. So I think we have different. I mean, when I moved here to this region about 10 to 11 years ago, I thought that I'll not see house dust mite allergy, while in fact the worst house dust mite you have seen is here. So it is quite prevalent, and I think our allergies are different from different parts of the world. Okay, so what's your experience with slitting kids? We use kid, either of you, Dr. Mariam, do you want to start?
Well, yeah, we do. We used it a lot. It's only because, parents, education is very important because a lot of parents, they prefer that the children grow up to help them in taking the decision. And I think this is something, a lot of parents, they don't like to take the decision on long-term medications. And this is, although it is only 3 to 5 years, but it is a burden because it have a compliance. It should be, given in the right time, the particular time of the day, and it is a burden on the parents. So this is very important fact that you should consider. Also, there is a lot of consensus between a lot of allergologists not to start before the age of 5. Okay, because you want to confirm that it is, a real allergic rhinitis, not like recurrent infections. Because, usually the allergic symptoms come also with the time of, flu symptoms. And less than 5 years is the age where there are a lot of recurrent infections. That's why majority of people, they believe that better to consider immunotherapy only after the age of 5. So I think by practice, you can, decide what is the best age, what is the best group, and also if the patients can tolerate the kids in particular, the skin prick test, or you go for one single, blood test. So you decide according to the cohort of patients that you have, and also according to the patient's parents' support that you will receive.
Excellent. Very comprehensive answer, Dr. Mariam. Prof. Ajib, are you routinely doing component testing before starting SLIT?
A very tricky question. Yes, I start doing it very, very frequent. Now, because there is one question was asking how to test and how to do. Again, the new guidelines is discussing how you should test. I think it's a stepwise approach. For non-expert, a stepwise approach. If you have, as Prof. Miriam mentioned, if you have a good clinical history suggestive of atopic nature, or you're suspecting that patient has either allergic rhinitis or allergic asthma, you start with what we call a baseline testing, which is either skin test or what do you call it, a specific IgE testing, which is namely before the RAS test. Now, you want to establish with this the sensitization. Is it exist or not? Now, unfortunately, with these old modality of testing, it does not really tells you what allergen it's been there. It gives you just the allergen there, but maybe could be cross reactivity. If, for instance, if one patient you skin test for dust mites and cockroaches, they came back positive, probably they cross react because of Derby 10, okay, or Blagia 10. Now that's the key thing. So if you establish the sensitization, then, and you discuss with your patients that the possibility of immunotherapy, especially with house dust mites, the possibility of immunotherapy, then I highly, highly recommend to get resolve component testing. Because with this, you really either you close your options or you increase your options. Because if you find that you have group 1, which is Derby 1, Derby 2, DERF 1, DERF 2, the options, it's much wider, okay? But if you start having Derby 1, Derby 2, Derby 23, Derby 7, Derby 5, your option become much limited to the products that really having the whole extract or the whole allergens. So I think it's very crucial, very important to do resolve component testing where is possibility of starting immunotherapy, especially in house dust mite. In the past, because one of the question also, it's very smart question, because in the past we says, we have to give the immunotherapy for 1 year to assess the effectiveness, because we didn't know which component was giving. We was just giving immunotherapy. But now when we give the right immunotherapy with the right component, I think we can reach to what I just showed, 2 to 3 months, you will see hopefully clinical effectiveness.
Excellent, and that's really very good. Dr. Mariam, is there, patients with type 2 inflammation? So, okay, they have allergic rhinitis, asthma, but they have atopic dermatitis. Do you think allergen immunotherapy will help their atopic dermatitis as well?
It can actually, but based on the literature, it is controversial. So you have to be careful, because this is, long and expensive medications. If it is for isolated atopic dermatitis, I will question it a lot, especially in the presence of a lot of new modalities like, biologics. Okay, especially if it is a mild or moderate to severe type of atopic dermatitis, and you don't want your patient to suffer for controversial option. However, if the patient is already having a lot of multimorbids, which is may suggest that this house dust mite or this problems is related to the allergens. So you can try it, or you can add it on top of biologics for the atopic dermatitis and other allergic modifications. So combining also AIT with biologics now is something that we are considering a lot in our practice.
We used to give, we still use Xolair for, I mean, I have I'm a bit skeptic. I'm skeptic by nature, but when it comes to allergen immunotherapy and severe asthma, I'm not sure what's your view, Dr. Adib. I mean, does it work? Doesn't work? Do we need to give it, etc., etc.? I mean, there is I think, from what we've heard, I think in the last session on this series of webinars, the contraindication are relative contraindication. I don't think there is a no to allergen immunotherapy. But what's your view on allergen immunotherapy for severe asthmatics?
Actually, yeah, I completely agree with you. The contraindication is relative, and again, because the way how the asthma was behaved and the limited options that we do have now. I always compare it with when we do desensitization for ARD patients and they are severely asthmatic. What we used to do, we give steroid, try to improve their FEV1 to become above 70. Then we do desensitization. We were trying to minimize the risk of exacerbations or bad exacerbation that patient need to go to urgent care. Now, I think with the newer modality of treatment that minimize the risk of asthma exacerbations and severity of asthma, like biological treatment, I think we can combine allergy immunotherapy as a disease modifying after starting biological treatment. So you start biological treatment for quite some time, you get patient under good control, then you may end up starting allergy immunotherapy. Actually, there's data coming from Japan talking about this, and it's been showing a good effect when it comes, and it's very well tolerated in severe asthma patients.
The same question, Dr. Mariam, about nasal polyps. Do you think they're helpful? Allergen immunotherapy has the smite. Do you think there is a rule for it?
This is very important because a lot of our colleagues from ENT, they believe in immunotherapy, particularly for house dust mite, based on very limited studies. One of them was from Egypt, where they did case control, and one arm they give immunotherapy, and one arm they without, especially post-surgical intervention, post-polypectomy. And there are some suggestions that, although it was very small number of patients, small sample size, and they identified that it may be beneficial as a preventive post-surgical, post-polypectomy. We don't have this belief because international consensus until now, they don't have this agreement about that. However, if the patient is highly positive for allergic and he have evidence of allergic rhinitis as well, it may help to reduce the inflammation, because the idea of immunotherapy is that it will reduce the underlying mechanism. Similar to the biologics. So biologics will work maybe on allergic or eosinophilic. So you will target one pathway, and then another pathway may grow up or become evident, and then you have to treat it. So in this way, if you give biologics, for example, for eosinophilic polyps, maybe now you subsided that, or even by surgical intervention, now the allergic part may show up. Okay, and this patient may come with more symptoms like allergic rhinitis, even asthma, and then this is the rule where you can interfere by giving it. But for particularly nasal polyposis, per se, it is not yet have any particular indication.
Excellent. I think to summarize the session, because I think we're approaching 10 o'clock, which we need to close the session. I think we've learned tonight the prevalence of the disease, the disease burden, and the diagnostic tests available to actually identify the culprit allergens and give the right treatment. And we've learned also that this is a very efficacious and safe therapy. So please, don't hesitate to use it. However, this is house dust mite allergy is an IgE-mediated disease or condition or inflammation. For immunotherapy to work, it has to be based on testing. So you can't start, because I think this is one of the questions here. Can we start allergen immunotherapy without testing? And the answer is no. We shouldn't be starting allergen immunotherapy unless we have evidence of IgE-mediated disease process. Now that applies to has the mite, pollen, molds, etc. So it is a very effective way of treating allergic conditions. And like Prof. Adib said, it does really modify the disease process. It's not only, and it provides symptomatic relief as well. So this is really a magical therapy when it works. And I've seen patients where they're off therapy. The final question is, how long do you treat for? I think because there are different schools, European school and an American school. And how, in your experience, how many years after immunotherapy symptoms reoccur? We'll start with Dr. Mariam and then briefly, and then Dr. Adib.
I mentioned this actually in my presentation, but in short, it's mentioned that, and this is an exam question, the board exam, it is 3 to 5 years, not less than that for the immunotherapy. And for how long the effect, it may last from 2 years up to 10 years. But the minimum that patients will benefit is at least 2 years post discontinuation of therapy.
Excellent. Dr. Adib?
I can add more. Basically, Prof. Mariam mentioned exactly what the data showed to us, which is 3 to 5 years. Actually, the last year it's the most important year, whereas basically the memory cells start to be produced. So that's what I insist with patients to not to be careful not to stop it, especially in the last year of third year. So 3 to 5 years, and I have experience with patients has been off treatment for almost more than 15 years, and it's no recurrence of the symptoms.
That's fantastic. Now, the reason I mentioned the durations, because there are some talks about, maybe making it 2 years, etc., because for compliance reasons. I mean, this was presented, I think some data presented a few years back in IACI, but I think 3 years, like you said rightly, is where the immune system, the memory immune system matures, and you have established T-reg cells and TMB reg cells there to protect the patients for the subsequent exposure. Now, it remains to thank you both for your excellent presentation. I think the discussion was amazing. We have, as I said, 270 participants, which is again really a very successful session tonight. And I would like to thank the participants for their persistence and eager to learn with lots of questions. And I'd like to ask to thank Stalajan Greer from WAAD for their excellent support for this webinar sessions, to Perel for their smooth running, except for my for my system. If I can share one last slide, just if I can go to my to just share one slide I just wanted to share with you. I'm not sure if you can be able to see it, I hope. The smooth running, except for my...
We can see it.
You can see it. Okay, just bear with 1 second. This is the last slide. Yeah, I'd like to invite everyone to... we are GACI and IACI are now partners, official partners, and we have a joint symposium at the IACI on the 15th of June for 1 hour, and it is delivered by Professor Arnis and Dr. Professor Adib as well, and Dr. Iman Nasr from Oman. So I'd like, if whoever is going to IACI, please join us to celebrate this excellent achievement for our group. So finally, it remains to thank you all for your participation and for having an excellent session. Until next time, have a nice evening and good night.
Thank you all.
Have a good night. Thank you so much.
Thank you.
يعطيك العافية يا بروف.
دكتور مريم، تحياتي، مع السلامة.